I'm Dr. Bart Rademaker, and this is the Doctor's Guide podcast, raw and unfiltered. And have you ever wondered, how to make the right decisions for yourself? I mean, you're faced with so many choices, right? You're faced with so many conditions and so many answers and so many opinions and so many influences out there. So who do you believe? And I recently learned this term, the believable factor. And so part of the challenge is that how do you actually, as a consumer, as a client, as a patient, really navigate all of that information? And even as a doctor, I mean, I'm a plastic and reconstructive surgeon. I speak 4 languages. I grew up all over the world. Even I have a challenge, to decipher some of this information. And so typically what I do is I go to those reliable sources because I also know who they are. And so that's partly the purpose of this podcast, to bring to you those believable sources that you can then further your questioning or your health journey with the right kinds of people, because you want the right kind of guide to help and support you with optimum health. And so part of the reason, or part of the process of this podcast actually is to recreate situations that you may have experienced yourself, or you may know that somebody else is experiencing that. And so how do we actually do that? We're going to do some role playing. And I'm grateful and blessed to have Dr. Ormond and Dr. Brewer on the show today, very accomplished physicians or health practitioners themselves, and to guide you as to how to navigate that process. And so Dr. Ormond will present with a specific problem, and then Dr. Brewer will guide Dr. Ormond with the process by which to get a resolution. So we're going to do that for about 6 minutes. And then we're going to unpack all of that. So as the listener, you'll get some insights, and you'll also get some action steps that you can proceed to get that kind of resolution. Now, in this role playing, my guests get to choose who they role play. And so it may not be something that's personally theirs, but certainly something that they can relate to as well. And for the purpose of this podcast, are sharing it with you today. And I say that specifically because Dr. Ormond has a specific role play, and you'll realize why I just shared that with you. And so before we get started, I'd like to introduce both Dr. Brewer and Dr. Ormond to the show, have them share a little bit about themselves. We'll start with Dr. Ormond today, and then later on we'll discuss, or they'll have the ability to share a lot more about what they do, and also give you the inspiration to go see them as well. So Dr. Ormond, Dr. Brewer, thank you so much for joining me today. And Dr. Ormond, just share a little bit about yourself, and then we'll go with Dr. Brewer, and then we'll figure out what role play you're going to play, and then we'll go into the role play as well. Dr. Ormond.
Awesome. Thank you. So my name is Dr. Matt Ormond. My background is a doctor of chiropractic, and I've gone into the world of kinesiology, sports medicine, and acupuncture. And I started my clinic working with athletes. And so over the course of nearly 17 years, I've seen about 85,000 different patients. And I've treated every patient encounter like just a lab. And in that time, I discovered I wasn't really treating neck pain or back pain or knee pain, but I was treating stress, treating physiological stress. So that's become the focal point, the niche that I found in my practice. Is I've really learned to listen for, to find the sources of stress and eliminate that stress and restore the body back to balance.
Yeah, and I think that's such an important component to any of the imbalances that we have within us that then also manifests in the physical form. Mm-hmm. And then we think it's just purely a physical form, and then we try to treat it with like in medicines, when in reality we need to be addressing something else. And we'll be talking about that later on after the role play. We actually had that conversation on the last podcast. And so for those listeners, this is an important element that you're going to want to focus on in order for you to optimize your health, especially if you feel that you're stuck. Dr. Brewer, a little bit about yourself.
Yeah, I'm an optometrist by profession, and kind of like same as Matt, I actually started my specialty practice as a sports division practice. So I played sports my whole life. I played, 4 in high school, played in college, and basically I love treating athletes. It's fun. So I started working with, volleyball players, football players, and then that developed into a concussion practice where, a lot of these athletes would get concussions. So I started treating that as well. And my background is more visual rehabilitation. So most people think optometrist is glasses and contacts, which I do that as well, but I also do a rehab side as well.
And that is such a big thing in our culture today is concussion. And it's a very interesting dynamic that happens with concussions. And so I'm very eager to find out more about what's going to happen during this role play. And so what is your role, Dr. Ormond?
So I am a 17-year-old female athlete. I've had several concussions over the past few years. My most recent concussion was 2 months ago. And I've been to a medical doctor. They told me to rest. And so I'm resting and it's not getting any better.
I'm going to call you Kim.
Very good.
Okay, Kim. So I looked at your history form and, I saw that you went to a medical doctor and a physical therapist and, they told you to rest and they said that the results were all negative. They did CAT scan, MRI, and everything came back pretty normal. Tell me what's happening with yourself right now. How are you feeling?
So, I feel like I don't sleep very well. I have a headache. It doesn't take long. I'm going to school and I can't read more than a couple pages without my eyes and it just feels heavy. I feel tired. I can't play my sport until I'm cleared to go back through my doctor. And so I'm just in this space. I don't know what to do. I'm depressed and I'm just frustrated.
That's really hard. I mean, I can only imagine how you feel like not playing your sport because I love playing sports too, and it really I'm gonna be honest, it sucks when you can't play. It affects you emotionally and mentally. Tell me about those headaches. You said you had headaches. Where are they located at?
So it feels like it starts in my eyes, but pretty soon it's my whole head. It feels like a helmet, but it's like tightened onto my head.
For sure. And you mentioned that you got them when you're doing reading.
That too. Yeah, the headaches are kind of constant. They're not as bad. Sometimes they're a little worse. But yeah, there's a certain amount of fatigue that just sets in. If I'm reading more than a couple pages, the headache gets worse. My eye fatigue is there.
Now, when you're reading, does it ever do the words ever look like they're moving or kind of have a shadow to it?
I would say so. As fatigue becomes worse, it still feels a little blurry almost. Like I have to just concentrate to make those words focus.
That'd be so frustrating. I mean,
yeah.
I can imagine, like you being an athlete and being in all these, really advanced classes in high school, and it must be hard for you. And are you able to get your homework done at all, or?
Sometimes yes, sometimes no.
Okay. Interesting. Yeah. And you said you had some sleep issues. Typically, what are you doing before you go to sleep? Let me ask you that.
Let's say that again. I'm sorry.
What do you do before you sleep? What are you doing
I'm on my phone. I'm talking to friends, checking stuff out.
Social media stuff, right?
Yes.
Yeah, gotta follow up on all the friends and family and whatnot. So okay, and typically, what time do you fall asleep?
Around 11:30.
11:30. Okay. Interesting. So, and then do you ever wake up at night?
Yeah. Oh yeah. It doesn't feel like I'm even sleeping sometimes. Sometimes I'm just kind of aware of myself resting and I can't tell if I'm asleep or awake.
Okay. So, you came here because I'm obviously an eye doctor and you're probably wondering, I saw in your history too, that you've been an optometrist in the last 6 months and it said that you got 20/20 vision, no glasses, you're not wearing contacts or anything. So I guess my first question to you is, what's your understanding of what 20/20 is?
Oh, that's a good question. Yeah. So what I understand is, that we think of 20/20 as perfect vision. So it means that I see perfectly well.
Spot on. And honestly, that's what everybody says. Well, probably about 95% of the people, literally they'll be like, yeah, perfect vision. And honestly, all 20/20 means is the top number 20 is that you're viewing a chart from 20 feet away. And the bottom number refers to the size of the letter. So you can have 20/40 vision. You can actually have better than 20/20 vision, which is 20/10. And a lot of the baseball players in the major leagues will have that kind of vision. So you can have better than perfect vision. So all 20/20 refers to is the clarity of how you see. Now, vision is a lot more complex than that. You actually have eye focusing, where your eyes focus. So like when you're reading, your eyes have to focus. There's a muscle in your eye that has to contract and focus the lens to make things clear at near. So if things are going blurry when you're reading, a lot of times you have a disconnect in that focusing mechanism. And when you have a disconnect, you can have eye strain, which can cause actually headaches over a course of minutes or hours. There's a lot more components to vision. It's how your eyes team together. So if your eyes don't work together as a team, you could have shadowing when you're reading, like almost like a double vision, but not quite double. Kind of looks like the words are moving. So a lot of times people will skip lines or have to reread lines and whatnot. So there's a lot of these components of vision in the visual pathway. There's eye teaming, eye focusing. You have to track with your eyes. And on top of that, you also have a whole like visual cognitive component where what you see, you still have to process it, and then you have to make a decision based off of that. So a lot of times when I'm training my athletes, I talk about vision, decision, action. So vision is the first part. What you see, is it clear? Is it double? Is it single? The next part is decision. So it's your brain taking that input vision and making something of it, packaging it together. And then from there, you have an action, whether you move your eyes, whether you feel fatigue in your eyes, or whether you feel headaches, or whether you're happy or whatnot. So that's kind of like the basic foundation of vision. And there's other inputs too that it's integrated with. So vision has a big connection with the vestibular system. So there's like actually a lot of inputs. There's like hearing, taste, smell, touch, proprioception, tactile. There's the vestibular system as well. So there's all these different types of sensory inputs that come in all day long. But vision has a really intimate connection between proprioception and the balance system, the vestibular system. So a lot of times when you get a concussion, it affects that relationship between those three inputs. So today what we'll do is we'll do a few tests to see what's happening. So we'll test your eye focusing system. We'll test your eye tracking, your eye teaming. We'll test your vestibular system, how it connects to the vision, as well as the proprioception system.
Yeah,
So from there, we're gonna have to like the task, basically. Yeah, like and in this scenario, there were deficits in the eye focusing system, eye tracking system, a little bit with the eye teaming, and the vestibular disconnect was crazy. So when we did like the modified CTSID, there was a huge disconnect in basically how they were balanced. So like if they were just testing the vestibular system, they'd fall over. They had major proprioceptive issues, which is interesting because you think that they would have nothing because she was a great volleyball player. But when you're actually testing those systems individually, there's a big disconnect, so that she had issues with her vision, vestibular, and proprioception, which caused a lot of these symptoms.
Awesome. Well, thank you so much, both of you. And just for the listeners, proprioception, that's the tactile, it's feeling, it's pressure, and then the vestibular is the ear. So, Dr. Ormond, what was that for you? What was going on, and why do you choose that?
So what was there for me is just, the information. It's awesome to see genius on display. And so I hear brilliance in what Dr. Brewer is sharing. And I think, from a patient's perspective, it's really always nice to know first that the doctor hears you and understands what you're going through, but then that they do have the knowledge base to find the solution. And so what you did, Dr. Brewer, is unpacked my symptoms, and then we're connecting dots along the way and just educating. Because again, I think pain or the symptoms that we have it can be scary because you don't know what it means exactly. And so your ability to connect the dots to what it actually means was super impactful.
Awesome. Paul, what was that for you?
Yeah, a lot of times it's interesting. We got a lot of great doctors out there, MDs, PTs, chiros, and chiropractors, and optometrists that see what concussions do to your other parts of your body. But there's a lot that just say, hey, go home and rest. And, most of the research nowadays, even when you look at like the Buffalo concussion protocol, like they're saying now, like, you should get prescribed active rehab 48 hours after a concussion. But a lot of times I see these patients months out, like literally months or even years. I have patients that come like a year and a half later, when they find me, and they're still having these visual symptoms, this vestibular symptoms, and all they've been told is to rest. And so I guess my point is, like, it's good to look for these things, look to see if they have an eye focusing or accommodative issue, if they have an eye tracking issue, if they have a eye teaming issue. And if they do, then can we do something about it in rehab? Can we rehab it? What I like to say is like, I like to normalize things, then optimize things. So normalizing is like they have a eye focusing issue that's below normal, which is causing headaches. So you bring it to normal, and then from there you optimize it and make them above normal so they can actually be more robust. So if they had a concussion again, it's less likely that they'll have the impact from the concussion affecting them.
Yeah, and just for the listener, with my limited understanding of concussion, and Paul, clearly, if I get anything wrong, please correct me, because we don't want to misguide, right, the
For sure.
listeners. But basically, when you do get a concussion, that's a major shock, and what results there is a lot of inflammation. And part of the challenge with the inflammation in the brain is that it's going to affect all the information transfer. And so you described different parts of the brain that are processing different information, whether it's visual, whether it's the balance from the vestibular area, and which is our labyrinth, or the proprioception, which is our spatial, feeling. And so with that information, those get disrupted. And part of the challenge, I think, with inflammation or concussion is that unless there's a very specific process to reduce that inflammation actually propagates more inflammation. And that's why these kinds of things can last for such a long time, and which is why, in my own personal experience, using stem cells to mitigate the inflammation, and we've seen that with veterans that we've treated for TBI, so that's traumatic brain injuries, concussions, obviously, with remarkable results. And so I'm curious, Dr. Brewer, specifically, because I just got a new insight, because that's what I would tell people is, look, rest, but you're telling me we need active rehab.
Prescribe active rehab. So a lot of times people think like, oh, go back and run 10 miles per hour, like right away, right? So like, there's a lot of, there's actually 3 different types of protocols developed by actually John Letty. He's a medical doctor that treats concussions, and it's called a Buffalo concussion protocol. But anyways, one is a treadmill test. Another one's a biking test, like a stationary bike test. And another one is like actually an active march test if you don't have those other, like a treadmill or a bike. But basically based off that one, like they do is they figure out your heart rate where your symptoms are elicited. So like, say like if your heart rate's at 130 and you start feeling those symptoms, that would be considered your max heart rate. And then from there, you do prescribe 20 minutes of aerobic exercise per day at 80% of that. So you're doing exercise at a rate that will not cause symptoms.
And what's the purpose of that prescribed rehab, though? I mean, how does it actually affect the inflammation or anything else that's going on in the brain?
A lot of it has to do with like, anything with blood flow, but really what it comes down to is like, for the brain to recover, it needs energy and activation. So energy is everything from nutrition to sleep to whatever. Activation is actually like activating the areas of the brain, or with aerobic exercise as well. So for me, as an optometrist, how I activate the brain is I activate the pathways that control eye focusing, eye tracking, eye teaming, visual processing as well. So when you activate those pathways, the brain's able to create different connections if they're damaged, or rehab the connections that have deficits as well.
And so what I'm understanding too, and correct me again if I'm wrong, is that when somebody does have a concussion, I think oftentimes what they probably do is completely ignore it, or they go to the ER, get a CAT scan, but they really should come to you when they have symptoms. And is it with any kind of concussion that they should come to you, for example, to get those measurements?
I think so, yeah. Because like what happens is we can at least get a baseline, and and based off normal data, we'd be like, hey, this is where you have deficits at. And then you have 2 pathways. One is, should we watch and see what happens? Because in reality, I mean, like, I'm going to throw out a number, I'm pulling a number out of the air, but like maybe like 70% of concussions self-resolve. But there's still like a 30% of them that will have persistent post-concussive syndrome. So after the 1 month, right? So I guess if you want to gamble, if you're that 30% or that 70%, in my opinion, it'd be better to at least get a baseline to see where they're at, and then kind of either do active rehab or follow it and see how they recover.
And so what kind of doctor do they look for then? Because I'm sure this is new information for a lot of people.
Right. Honestly, any doctor that does visual rehab, I mean, there's a neuro-optometrist, even neuro-ophthalmologists that actually do rehab, because there's two camps, one that does more surgical and one does more rehab. Some PT.
So they just have to ask. They just have to ask for visual rehab. Is that it?
Yeah, and if you go to if you look up neuro-optometrist, you can find links for that as well. There's there's NORA, which is a neuro-optometric rehab association. And there's websites like that where they can go to look up doctors that actually treat that kind of stuff.
Yeah, so I'm gonna have to call a friend of mine that I just advised recently about their concussion. He is a young teenager and got a knockout during his first boxing experience. Interesting. So I know that Paul and I have been doing all the talking. Matt, what do you want to share?
I love this. I could listen to you guys go after it all day. What was present for me is just your question, Dr. Bart, is like, where do people find this information out? Because it's the going, well, I'll put in a frame, there's 12 cranial nerves. 4 of those 12 cranial nerves go right through the eyes. Then you add the vestibular and cochlear function there. We have half the cranial nerves are in those areas. And so when concussed, these are areas that will be affected. And I've looked at concussions through my lens, and I'll do various tests. And essentially, and I heard you describe this, Paul, is bringing the hemispheric communication back together again is really such a vital key. Because again, my vernaculum is where electricity goes, blood flows. And there's parts of the brain that just no longer have great blood supply, whether it's due to accumulation of inflamed just tissue or swelling that's blocked off, new oxygenation to those areas. But this is it's vital to get new blood flow, to get new activations, your words, to those areas. And so I think, this information, while concussion is a very, it's a hot topic that we're learning more and more about, I think we're still just scratching the tip of the iceberg, obviously, after speaking with you.
So my question then, and thank you for that. My question then again too is that how much of a bang, do you begin to get worried about? I mean, somebody smacking me on the head versus a knockout. I mean, there's a big difference there. But where does it get pretty clear that I need to see a neuro-optometrist?
Oh, for sure. And that's actually a good question. When we talk about definitions, right? And the definition of mild TBI, concussion, moderate TBI, that's changed I don't know how many times, every few years. I was actually just in Ireland at the a concussion conference there, and they were actually coming up with a new definition or updated definition for mild TBI. And then they were comparing when is it a concussion versus a mild TBI, and there's all these different criteria. There's 6 criteria. One is imaging, and another one's symptoms, signs, and whatnot. And based off those criteria, you're going to either fall into concussion, mild TBI, or severe TBI. And that's the hard part, is first defining and who believes which definition is right. Ultimately, what it comes down to is that if you have symptoms, if you have issues, if you feel like you're not at normal, you should probably, and this is my opinion, and I actually was on a panel this last year where we had a MD, chiropractor, physical therapist, optometrist, athletic trainer, and we did this panel for concussions at different conferences. And it was cool to see different professions and see how we all treated it. And ultimately what comes down to is I think there should be an interdisciplinary team, including everyone from every profession, where they do their thing, where they have their expertise.
But for the consumer, right? So obviously if someone gets knocked out, well, that's a trip to the ER, right?
Correct. Yeah.
Right. What about just get a big knock and you're just a little dizzy for about 30 seconds? Is that, ticket to the ER too, or do you just sit and wait?
See, that's a hard question, because really that usually that's in a training facility or maybe in a game, right? So an athletic trainer, a lot of times will follow what's called the absence of suspicion test. So like basically if they have certain criteria met, then it goes to the ER. If it doesn't hit those criteria, then most likely they don't. But a lot of times people err on the side of, like it's bad and send them to the ER anyways. And I guess ultimately it's better to go to the ER and find that there's nothing wrong than not going and having something that's bad.
So basically, I mean, you could be hitting the head and it just hurts like hell versus you're having some other symptoms where it just gets a little blurry, maybe it's a little, auditory loss, so hearing loss, or some sort of imbalance, with the knock. That's probably, enough of a reason to get further evaluated. And then with some imaging like a CAT scan typically, without contrast, right? And then obviously if you've already gone to the ER, then you might as well go see someone like you. Basically.
Yeah, correct. So if you have like imaging and it's all negative and there's no major issues like, some kind of injury like herniation or whatever.
So let's say it's negative. So
it's all negative, yeah.
Then but I'm still dizzy.
And then I would go actually come see me. Yeah, I would do some baseline testing, see where they're at, because there's a lot of things you can do to kind of create new pathways to basically make the vision, vestibular, proprioception work better together.
Okay, so basically any symptomatology, any symptom after the fact, then it's let's go see you, and potentially even not getting the CAT scan, right? But just see you at least and do some metrics, and then. Because sometimes concussions can be delayed, right?
It can be, yeah. And honestly, like everyone heals differently. It's kind of interesting because with concussions, like everyone follows a different pathway. So like you treat one concussion, it's not like you treated every single one. Every patient has generalities that are similar, but they're all different, which throws obviously a curveball each time. But I would get assessed every single time. I mean, especially if dizziness can be visual or it may not be. It could be it could be cervicogenic. It could be other things too. So it's always good to get checked from at least an MD, physical therapist, chiropractor, OD as well.
So I've totally deviated from my normal practice on this podcast because I had one patient and I was kind of still in the dark, and I basically said, "Look, go to the ER anyhow." But for the listener, this is what the takeaway that I want you to hear. And then again, correct me if you have any adjustments, both of you, by the way, is that if you get a pretty significant knock and you have no symptoms, you haven't lost eyesight, you're not dizzy, it's just like an instant thing as you got knocked, maybe a second or two, you're done, fine. But if it's anything more prolonged than the actual knock itself, so we're talking 2-3 seconds after the knock, or even worse than that, then absolutely go to the ER. Get checked, and if you're not doing that, at least and you're symptomatic, at least get the assessments, because the assessments is something that I was not aware of. I don't think many people are aware of. We all know about get a CAT scan, but sometimes those are delayed. And then even if you present with a couple of symptoms a day or two later, even nausea, even vomiting, anything like that, even with a negative CAT scan, get assessed. Because that's where that active rehab can come into play, because getting a concussion can be pretty serious. Would you add anything else to that, either Matt or Paul?
If I may add, just there's some subtlety involved here. I hear Paul just really navigating the subtlety, in addition to the majors, but even like post concussion, we'll see like mood disturbances. Like someone who's generally, cheerful or, optimistic, right, or whatever. Like that's something that's not a small thing. It's more subtle, but it's significant. Sleep disturbances are another thing that, again, we kind of just like, we don't necessarily stack these symptoms together, but, post concussion, it's just being the awareness of stacking these symptoms together, because it does affect things. And sometimes it's not the dizziness or visual disturbances, but it is like, wow, you know what, he no longer, his appetite's changed, or, there's subtle things that are important.
So anything out of the norm, go get checked. Excellent.
Yeah. Well, and a lot of times go ahead. Sorry.
No, go ahead.
I think a lot of times people wait too long. Like, again, I was telling you earlier how like I see people a year and a half after the fact. So they got a year and a half literally out of work or going half pace at work and just trying to push through it when they could have gone like at 3 months or a month out and got the right help.
Well, a key takeaway is, whether you get instant, symptoms, or even a week or two later, or even a month later, go get checked. Don't wait. It's pretty serious and it can affect a lot of different things. Well, I want to thank you both. I like to wrap it up first with Matt. How do people get a hold of you?
Thank you. So email is a good way. It's dr.matthew.ormond@gmail.com. I'm on Facebook with Matthew Ormond. I'm on Instagram with Matthew Ormond, also Dr. O. And I respond in any of those formats.
Great. Paul?
Yeah, you can reach me by email, Brewer PM, BREWER PM @gmail. I'm also on social media. So I'm on social media. Username is a Diverge Neurovision. So DIVERGE Neurovision.
And you all heard him say he's okay getting texts and also responsive to your questions. And certainly when it comes to things like this, absolutely, reach out to them. So I want to thank you both. I deviated from my normal practice. I usually let you guys do all the talking, but I really want to make sure that people understand some simple steps, simple awareness. You talked about that too, Matt, and how to move forward. And this is not something that is ever trivial. Any symptom is significant and must be checked out. I'm Dr. Bart Rademaker. This is the Doctor's Guide podcast, raw and unfiltered, bringing to you some incredible individuals like Dr. Ormond and Dr. Brewer today to help guide you through the process of optimizing your health. These are believable sources. Your job is to find those believable sources, have the discernment to make the right decisions, because ultimately it's entirely up to you. You certainly don't want to wait a year and a half before you want to do something about it. That's just a waste of time. Thank you, and we'll be back.